actually sit down with a source material, and we are talking about a dense, comprehensive medical text on hematologic disorders today, you realize that the popular understanding is just skimming the surface. We are talking about sickle cell syndromes.
It is one of those topics that when you really look at the mechanics of it, it changes how you view human biology. It's not just about anemia or pain. Those are, of course, huge parts of it.
Right.
The text frames this as a masterclass in molecular shapeshifting.
Shapeshifting is exactly the phrase that grabbed me when I was reading through the prep notes.
Yeah.
We usually think of our bodies as having this stable architecture. Bones are hard structural beams, blood is a liquid river.
Sure.
But here, we have a condition where a single, tiny genetic change alters the actual physical state of your blood. It stops being a fluid and becomes, well, the text calls it a semi-solid gel.
That phrase, semi-solid gel, is the key to unlocking this entire deep dive. It sounds like science fiction blood turning into jelly inside your veins, but that is the physiological reality.
It's incredible.
And that transition from liquid to gel is what drives every symptom, every crisis, and every treatment strategy we're going to discuss.
I want to get to that gel concept because it is mind-blowing, but we need to set the stage properly first. The source material refers to sickle cell syndromes, plural.
Yes.
I feel like in casual conversation, people often conflate having the trait with having the disease.
They absolutely do, and clarity here is essential because the clinical reality is it's night and day. It all comes down to the genetic lottery, specifically Mendelian inheritance.
Okay.
We are talking about the hemoglobin gene. In a standard default setup, a person inherits two normal beta-globin genes. They produce hemoglobin A. That is your standard adult hemoglobin that keeps your blood round and flowing.
Okay, so hemoglobin A is the baseline. That's the normal setting.
Correct. Now let's look at sickle cell trait, or SCT. This is a heterozygous inheritance.
Heterozygous.
That means the person has inherited one normal gene producing hemoglobin A and one sickle gene producing hemoglobin S.
So they have one foot in each world, a mixed bag.
Exactly. And the text is very specific about the clinical reality for these individuals. People with sickle cell trait are usually asymptomatic.
Usually.
For the vast majority of their lives, they are carriers. They aren't patients. They are walking around, playing sports, living normal lives, and their blood is, for the most part, behaving itself.
However, the source material did flag one specific exception. It said, usually asymptomatic. But there is a rare red flag that people with the trait need to know about.
You caught that. It's hematuria.
Blood in the urine.
Blood in the urine, yes.
Which sounds alarming.
It is alarming, but it's usually painless. The text explains that even though these individuals have enough hemoglobin A to prevent the disease, the conditions in the kidney are uniquely stressful. So sometimes, under heavy stress or extreme exercise, you might get a little bit of sickling there. But again, to be clear, for 99% of the experience, the trait is clinically silent.
Okay, so that's the trait. Now let's step into the deep end. Sickle cell disease. This is the homozygous form, historically called sickle cell anemia.
This is when you inherit the sickle gene from both parents. You have hemoglobin SS.
So no hemoglobin A.
There is no hemoglobin A to balance the scales. The text does mention there are compounded forms like hemoglobin SC or sickle beta thalassemia, which are complex hybrids. But for the sake of understanding the core mechanism today, we are focusing on that classic hemoglobin SS profile.
So let's get into the why. We have this hemoglobin S. What is it actually doing inside the red blood cell that causes such chaos? Because the description of the transformation in the notes is terrifying. It's not just that the cell doesn't work, it physically changes.
It really is a transformation. And the irony is that it all hinges on oxygen. When hemoglobin S is oxygenated, when it's fresh out of the lungs, bright red and full of air, it functions reasonably well. It's soluble. It's fine.
It floats around in the cell just like normal hemoglobin.
So as long as it's holding on to oxygen, it's behaving.
Ideally, yes. But the problem arises upon deoxygenation. When that red blood cell travels down to your leg or your liver, delivers its oxygen payload to the tissues, and becomes empty, that is when the monster wakes up.
This is where we get to polymerization.
Yes. In normal blood, empty hemoglobin just floats there, waiting to go back to the lungs. But hemoglobin S molecules, without oxygen, they essentially become sticky.
Sticky.
They have a hydrophobic patch that gets exposed, they seek each other out, they lock together and polymerize into long, rope-like fibers.
So visualize this. The inside of the cell goes from being a water balloon filled with liquid to being filled with stiff structural ropes.
Exactly. It becomes a semi-solid gel. And these fibers don't just sit there. They grow. They physically push against the cell membrane from the inside out.
That is such a vivid image. It's not just that the chemistry changes. The internal structure forces the cell to distort. It forces the cell into that characteristic crescent moon, or sickle, shape. And that shape change is catastrophic for two main reasons. First, viscosity.
It gets thicker.
The blood becomes physically thicker. And second, what the text calls sludging.
Sludging. It's a visceral word. It sounds exactly like what it is.
It's accurate. Normal red blood cells are biconcave discs. Think of them like donuts without the hole. They are soft, squishy. They can fold themselves in half to squeeze through the tiniest capillaries in your eyes or your fingertips.
Right.
But a sickled cell, it is rigid. It's like trying to push a crescent-shaped rock through a garden hose.
It gets stuck.
It gets stuck. And this creates a vicious cycle. The text calls it a feedback loop of destruction. Let's walk through it.
Okay.
The sickling happens because oxygen is low, right?
Right.
So a cell sickles and gets stuck in a capillary. It blocks the flow. Now, no fresh blood can get to that area. What happens to the oxygen level in that trapped area?
It drops even lower because no new oxygen is arriving.
Exactly. You get local tissue hypoxia. The oxygen plummets, which causes more hemoglobin in the surrounding cells to deoxygenate and polymerize.
Oh, wow.
Which causes more sickling, which makes the blockage bigger. It feeds itself.
It's a snowball effect.
Yeah.
And meanwhile, the cell membrane itself is taking a beating from all this shape-shifting.
It's being traumatized. There is a cycle of sickling and unsickling. The cell might get stuck, then eventually break free, get back to the lungs, get oxygen. The gel melts back into liquid, and it relaxes.
But you can only do that so many times.
You can only bend a piece of plastic back and forth so many times before it creates a stress fracture.
Eventually, it doesn't snap back.
Correct. We call that irreversible sickling. The membrane is so damaged, it stays in that sickle shape permanently, even if you give it oxygen. And the body, being smart, recognizes this. The spleen and the immune system look at these damaged cells and say, this is garbage. We need to recycle this.
So the body destroys its own blood cells.
It eats them up. This is the hemolysis part of the equation. A normal red blood cell lives about 120 days. A sickle cell might survive only 10 to 20 days.
That's a huge difference.
The bone marrow factory simply cannot keep up with that level of destruction.
So you're consistently running a deficit. That's the anemia part of sickle cell anemia.
Exactly. You have the anemia, not enough oxygen carriers, and the vaso-occlusion, the blockages causing pain and tissue death. That is the dual threat of this disease.
I want to pivot now to the timeline of this because this was one of the most fascinating parts of the source material for me. If you have a baby born with sickle cell disease, genetically, they have it from conception. The blueprint is there, but they don't show symptoms immediately.
No, they don't. And this is critical for parents to understand. There is a protection period.
A grace period.
In a way. The text states that symptoms are usually delayed until 4 to 6 months of age. And the reason for this is something called fetal hemoglobin, or HbF.
This is the different type of hemoglobin we all have when we are developing in the womb.
Right. When you are a fetus, you aren't breathing air. You have to steal oxygen from your mother's blood across the placenta. So evolution gave us HbF, which is like a super magnet for oxygen.
Okay.
But here is the magic trick relevant to our deep dive. Fetal hemoglobin does not sickle.
It's immune to the polymerization.
Completely. And not only that, it actually interferes with the process. If you have enough HbF floating around in the red blood cell alongside the HbF gets in the way of those ropes forming. It stops the gel from setting.
So for those first few months, the baby is protected by their own lingering fetal blood system.
That's right.
But then the fetal switch flips.
The body says, okay, we're out in the world now, time to switch to the adult system. Around 4 to 6 months, HbF production shuts down and the beta-globin genes kick in.
Got it.
In these patients, that means the factory starts pumping out sickle hemoglobin, HbS. As the HbS replaces the HbF, that protection fades and the symptoms begin.
And the text mentions that one of the very first signs, often the way parents discover something is wrong, is something called dactylitis.
Hand and foot syndrome. It's heartbreaking to see. You have an infant who is suddenly crying inconsolably, and you see painful swelling of the hands and feet.
Why the hands and feet specifically?
It's a circulation. The small vessels in those tiny extremities are very prone to that sludging we talked about. The sickled cells block the blood flow, causing infarction. Infarction basically means tissue death due to lack of oxygen. So the baby is effectively having a tiny heart attack, but in the bones of their hands and feet.
That is an incredibly painful thought. And that pain brings us to the concept of the crisis. You hear this term all the time, sickle cell crisis. But the source material makes it clear that crisis is just an umbrella term.
Right.
There isn't just one type, and they act very differently.
No, and distinguishing them is vital for treatment. The most common one, the one most people associate with the disease, is the vaso-occlusive crisis.
With pain crisis.
Right. This is exactly what we describe with the sludging. A vessel gets blocked, bone, muscle, organ somewhere is not getting blood. The text notes a key diagnostic point here. These patients will have severe pain over the involved areas, but, and this is crucial, their hemoglobin levels might be at their baseline.
So you check their blood count, and it looks normal for them, but they are in agony.
Correct. The crisis isn't that they suddenly lost blood, it's that the blood they have is stuck. But then you have the aplastic crisis. This is totally different.
This is the factory strike.
Yes. This is usually triggered by a virus. Parvovirus B19 is the classic culprit. It infects the bone marrow and essentially shuts down red blood cell production.
And since their red blood cells only live for a couple of weeks anyway.
If the factory stops for even a few days, their blood count crashes. The text says to look for a decreased reticulocyte count.
Reticulocyte?
Reticulocytes are baby red blood cells. If that number is low, it means the marrow isn't making new ones. The patient gets incredibly pale, fatigued, dyspneic. It's an acute emergency because they are running out of oxygen carriers entirely.
And then there's the third one, splenic sequestration. This one sounded the most immediately life-threatening, especially for little kids.
It is a leading cause of death in young children with the disease. The spleen is basically a big filter and storage tank for blood. In sequestration, something goes wrong with the outflow. The spleen massively enlarges and traps a huge volume of the body's blood inside itself.
It's internal bleeding, but into an organ.
Effectively, yes. The circulating blood volume drops precipitously. The child goes into shock, hypertension. If you press on their belly, you can feel the spleen. It's huge and hard.
Wow.
You have to get fluids and blood into them immediately, or they can die from cardiovascular collapse.
The spleen really seems to be the tragic hero, or maybe the primary victim of this entire disease. The text spends a lot of time on functional asplenia. It sounds like the spleen takes a beating.
It takes the worst beating. Think of the spleen as a fine mesh filter. It's designed to catch bacteria and scrub old cells out of the blood. But because it's such a tight mesh and the blood flow is slow and winding, it is the perfect place for sickle cells to get stuck.
So it gets clogged first.
Constantly. The text explains that repeated infarctions, tiny patches of tissue death inside the spleen, happen over and over again starting in infancy.
It's basically dying by 1,000 cuts.
Eventually, it turns into scar tissue. By adolescence, the text says the spleen may effectively destroy itself. It shrinks down to a nub of fibrous tissue. We call this autosplenectomy.
The body performs its own spleen removal through accumulated damage.
Exactly. And this isn't just about losing an organ you can live without. The spleen has a very specific job: opsonization.
That is a great word, opsonization. Let's unpack that for the listener.
Think of it like putting sprinkles on a donut or handles on a slippery suitcase. Bacteria have slippery coats that make them hard to catch. The immune system has trouble grabbing them. The spleen's job is to coat these bacteria with proteins opsonins that act like handles for the white blood cells to grab onto and destroy.
So without the spleen, the bacteria are effectively invisible, or just too slippery to catch.
Too slippery. The immune system can't clear them efficiently. The text highlights encapsulated pathogens specifically, and Streptococcus pneumonia is the big killer here. Without a functioning spleen, a simple ear infection or sinus infection can turn into overwhelming sepsis in hours.
This explains why the text is so adamant about fever.
A fever in a sickle cell patient is a medical emergency, period. You don't give them Tylenol and wait to see if it breaks. You have to assume it's sepsis until proven otherwise because they lack that splenic defense.
That's a heavy burden for parents. Every fever is a panic button.
It is, but knowing that mechanism is what saves lives.
We've covered the acute crises, but the list of complications in the source material just keeps going. It really drives home that this is a systemic disease. It's not just blood pain. One of the major acute complications listed is acute chest syndrome.
ACS. If you look at mortality stats for adults with sickle cell, this is often the top cause.
What is it exactly? Is it pneumonia?
It mimics pneumonia. The definition is a new pulmonary infiltration. Basically white stuff showing up on a chest x-ray where it should be clear, accompanied by respiratory symptoms like cough, chest pain, or low oxygen levels.
But it's not always an infection.
That's the tricky part. It can be triggered by infection, sure, but it can also be caused by fat embolism from bone marrow or, and this is common, infarction in the lung itself.
So the vessels in the lung get clogged.
The vessels in the lung get clogged with sickle cells.
Which explains why the text says the response to antibiotics is often equivocal.
Right. You throw antibiotics at it because you have to cover for infection, but if the cause is sludge in the lungs, antibiotics won't dissolve that. It's a very dangerous situation because if the lungs can't oxygenate the blood, what happens?
More sickling.
Exactly. Systemic hypoxia. It triggers a massive sickle wave throughout the body.
Another complication mentioned, which I think needs to be discussed because it's often stigmatized or misunderstood, is priapism.
It's vital we talk about this because the silence causes delays in treatment and time is tissue. Priapism is a painful, unwanted, sustained erection.
And the text is clear. This is not a sexual event.
Not at all. It is a vascular blockage event. The sickled cells trap blood in the corpus cavernosum, the sponge-like chambers of the penis, and the blood cannot drain out.
Well, it's emergency.
The text emphasizes this is an emergency. If that pressure stays high for too long, it causes fibrosis and permanent erectile dysfunction.
The treatment mentioned sounds intense.
It is. Aspiration using a needle to drain the blood, and potentially injecting vasoconstrictors to force the blood out, or vasodilators to relax the smooth muscle. It requires urgent medical attention, but patients are often embarrassed to go to the ER. We need to normalize that this is a vascular crisis, just like a stroke.
Speaking of stroke, that is listed as a major risk, particularly in children.
Yes, the sickled cells can block blood flow to the brain. This is why we screen children with specialized ultrasounds to look at blood flow speed in the brain. If it's too fast, it means the vessels are narrow and we have to intervene.
And beyond these acute events, the source lists a wear and tear, lists chronic organ damage, pulmonary hypertension, bone destruction, gallstones.
Gallstones are almost inevitable. Because of the high turnover of red blood cells, you have a lot of bilirubin, a waste product of blood breakdown. It builds up and forms stones.
Right.
You also see renal complications, delayed growth, delayed sexual maturation. It highlights that this disease is constantly attacking the body, even on the good days.
Which brings us to the strategy. How do we fight back? The text breaks this down into maintenance and acute management. Let's start with defense. Given what we said about the spleen and the immune system, the first line of defense seems to be penicillin.
It seems counterintuitive to give antibiotics to a healthy kid, right? We usually tell people not to overuse antibiotics, but here, this is the prophylactic shield.
Explain the rule.
The text is strict. Penicillin prophylaxis starts at 2 months of age and continues until 5 years of age.
Why does it start at 2 months?
That aligns with the fetal switch we talked about. That is when the spleen function starts to dip and the fetal protection wears off.
And why stop at 5?
By age 5, the child's immune system has matured enough, and they've had enough vaccines, that they can usually handle those encapsulated bacteria without the daily penicillin shield. The risk of that overwhelming sepsis drops, though it never goes away completely.
And the dosing. The text got very specific, which I appreciate.
It did. 125 milligrams twice daily up to age 3. Then you double it to 250 milligrams twice daily until age 5. It's a non-negotiable part of care for these kids to prevent death from infection.
Alongside vaccinations, of course.
Standard routine plus heavy reinforcement on the ones the spleen would normally handle. Influenza, meningococcal, and pneumococcal. You are essentially building an external immune system because the internal one is compromised.
The notes also mentioned folic acid. 1 milligram a day.
That's logistical support for the bone marrow. If you are forcing a factory to run at 500% capacity to replace destroyed red blood cells, you better make sure it has the raw materials.
Makes sense.
Folic acid is a key ingredient in making DNA for new cells. If they run out, the factory stops, and you get a secondary anemia on top of the sickle cell anemia.
Okay, so that's the baseline defense. But then the source material introduces a drug that feels like the closest thing we have to a cheat code for this disease. Hydroxyurea.
Hydroxyurea is a game changer. If you recall, we talked about the time machine effect, how fetal hemoglobin, HbF, protects newborns.
Right, the HbF interferes with the gel formation. It keeps the blood liquid.
Hydroxyurea is a pharmacological time machine. It works by stressing the red blood cell production just enough to trick the body into reactivating those fetal genes.
So it forces the body to make fetal hemoglobin again, even though the patient is an adult.
It does. It increases the levels of HbF inside the adult cells. And remember, HbF doesn't sickle. So if you can get that HbF level up, you dilute the sickling effect. You prevent the polymerization.
That is incredibly elegant. It's using the body's own backup system against the disease.
It is. The text indicates it for patients with frequent pain episodes, severe anemia, or a history of acute chest syndrome. The data is clear. It reduces crises, reduces hospitalizations, and reduces mortality. It attacks the root cause, the polymerization itself.
But there's always a but in medicine. It's not just a vitamin.
No. It was originally developed as a chemotherapy drug. It works by suppressing cell division. So there is a very fine line, a tightrope walk, between efficacy and toxicity.
You want to suppress the marrow enough to switch the genes, but not enough to shut down the factory completely.
Exactly. That's why the text is so obsessed with the monitoring numbers here. You have to check the blood counts constantly.
What are the numbers we're watching for?
We are watching for myelotoxicity bone marrow poisoning. The text gives specific cutoffs. If neutrophils drop below 2,000, stop. If platelets drop below 80,000, stop. If reticulocytes drop below 80,000, stop.
And then what? You just quit the drug.
You hit the brakes. Stop the drug for a week, let the marrow recover, then you restart, but at a lower dose. It's not a take this pill and call me in a year situation. It requires active management. But for those who can tolerate it, it changes the trajectory of their life.
Now let's shift gears to when things go wrong. Acute management. A patient is in the ER. They are in a vaso-occlusive crisis. They are in agony. This section of the text had a bold warning that stood out to me. Avoid meperidine.
This is a classic board exam question and a critical clinical rule. Meperidine, you might know it by the brand name Demerol, is an opioid. It's a strong painkiller. But it has a dirty secret when it comes to long-term use. When the body breaks down meperidine, it creates a metabolite called normeperidine.
And normeperidine is the villain in this story.
It acts as a neurotoxin. It lowers the seizure threshold. It can cause tremors, anxiety, and full-blown seizures.
And since sickle cell patients often have some level of kidney impairment,
They can't pee it out, it accumulates in their blood. So you were giving them a painkiller that might cause them to have a seizure. The text is explicit. Do not use it.
instead they recommend morphine or hydromorphone. But there's a social note here that I think is really important to highlight. The text explicitly addresses the addiction myth.
This is crucial, and frankly, it's a matter of justice and equity in healthcare. The text states, suspicion of addiction commonly leads to suboptimal pain control.
That's a polite medical way of saying doctors don't believe the patients.
Exactly. You have a patient in excruciating bone-crushing pain. But because they look normal, remember, their hemoglobin might be at baseline, and because they might know the specific names or doses of the drugs that work for them because they've been doing this their whole lives, staff get suspicious.
They get labeled as drug-seeking.
And they get undertreated. The expert consensus in this text is clear. Aggressive pain control minimizes dependence. If you chase the pain, if you make the patient beg for every dose, they stay anxious, the pain stays high, and the psychological dependence grows.
Right.
If you control it properly with scheduled dosing, the outcomes are better. We have to trust the patient's report of pain.
Now, what about transfusions? The disease is called anemia, so the logical leap is give them blood.
It's a logical leap, but a dangerous one. Transfusion in sickle cell is not like transfusion in a trauma patient. You have to be incredibly strategic.
Why? What are the risks?
There are 3 big ones mentioned. First, iron overload. The body has no natural way to get rid of excess iron. Every bag of blood is a bag of iron. If you give too many, the iron builds up in the heart and liver and becomes toxic.
Second,
Hyperviscosity. Remember, the fundamental problem is that the blood is thick and sludge-like. If a patient has a hemoglobin of 7, their body is adapted to that. If you pump them full of blood and raise them to a 10 or 11, you are making the blood thicker.
you could make it worse.
You might actually cause a stroke by making the sludge worse.
So sometimes less is more.
Exactly. And the third is alloimmunization. This is fascinating and frustrating. Sickle cell patients often need blood from donors, but the donor population and the patient population might be ethnically different. Minor antigens on the blood cells might not match perfectly.
The immune system notices the difference.
It starts making antibodies against the donor blood. It recognizes the fingerprint of the donor cells as foreign. With every transfusion, it becomes harder and harder to find a match. So you save transfusions for the big moments, stroke prevention, pre-op, or those acute crashes like the aplastic crisis. You don't just use it for a routine pain crisis.
We've talked about maintenance, we've talked about crisis management, but is there a cure? The source material mentions one way out,
Yes. Allogeneic hematopoietic stem cell transplantation.
a bone marrow transplant.
Currently, it is the only curative therapy discussed in this text. You essentially wipe out the patient's defective bone marrow with chemo and radiation destroying the factory that makes the sickle cells, and you replace it with healthy marrow from a donor.
If it works, they start producing hemoglobin A.
Yes. They are cured, they no longer have sickle cell disease, their blood stays liquid.
So why isn't everyone doing this? Why are we still relying on penicillin and hydroxyurea?
Because the cost, the biological cost, is incredibly high. The mortality risk from the procedure itself is significant. There's graft versus host disease, where the new immune system attacks the patient's body. There's the risk of secondary cancers later in life.
So it's a high-stakes gamble.
And you need a match. The text specifies the best candidates are younger than 16, have severe complications, and have an HLA-matched donor, usually a sibling. For many patients, that perfect donor just doesn't exist. So while it is a cure, it's not an accessible cure for everyone yet.
It's amazing to think about the journey we've just taken. We started with a single DNA typo-conner, a tiny change in one protein, and traced it to a blood cell turning into a gel, blocking a vessel, destroying a spleen, and requiring a lifetime of antibiotics, monitoring, and potentially chemotherapy or transplant.
It really highlights the interconnectedness of human biology. One structural change in a molecule dictates the fate of organs as distant as the brain, the kidneys, and the bones. It shows how fragile that architecture really is.
And yet, the solution, or the best management we have right now with hydroxyurea, comes from looking back at our own development. The fact that the fetal hemoglobin, the stuff we threw away when we were 6 months old, is the key to treating the disease in adults.
Right.
That is just poetic.
It is. It shifts the perspective from just treating the crisis to understanding the molecular biology. By understanding why babies are protected, we found a way to protect adults. It's a perfect example of how deep scientific understanding translates into life-saving therapy.
So for everyone listening, next time you hear sickle cell, don't just think anemia. Think about that molecular shape-shifting, the semi-solid gel, and the incredible balancing act patients and doctors perform every day to keep that blood flowing.
Well said.
That's it for this deep dive. We'll catch you on the next one.